At the outset, I would like to thank the organizing committee for inviting me to share some of my experience and thoughts about the chronic kidney disease. It is actually the topic itself I thought is a bit challenging because the topic given to me is to talk about the current challenges to the internists. A new form of chronic kidney disease started to rise its head during the turn of the millennium, and it was noted by the consultant physicians who was working in the Anuradhapura hospital at the time. And during the next 2 decades, it spread into the adjacent provinces, the northwestern province and the Wu province. Because the disease was not due to conventional risk factors, it was termed the chronic kidney disease of unknown etiology. Just to give you an overview of the disease has a male preponderance. The majority affected are farmers. People who are affected are usually at a younger age than the diabetic kidney disease, asymptomatic in the early stages, and the disease is slowly progressive, and the renal biopsy shows tubulointerstitial disease. And the end-stage renal disease needs dialysis and renal transplant. The CKDu prevalence, various studies have reported the prevalence between 5 to 15% in the North Central province. Although we do not have good renal registry data, it's very difficult to estimate the numbers that are undergoing treatment, but approximately about 20,000 people in the region are undergoing treatment. Annually, about 2,000 new patients treating treatment. About 4 to 5% of our health budget is spent on the treatment. And in addition, there's a huge socio-economic burden. I'll not go through this slide, but you can see the major burden of the chronic kidney disease is in the North Central province, the Anuradhapura and the Polonnaruwa districts, and some areas in the Ampara, Badulla, Matale and Kurunegala districts are also affected. You can see the quite discrete geographical distribution of the disease. CKDu is most prevalent in the North Central province. So I'll concentrate my talk onto the North Central province where my experience is in the North Central province. I must admit I have not worked as a physician in the region, but I have had frequent visits to these areas for my research studies. I have visited almost all these hospitals I'm going to talk about and met the physicians. So in the Anuradhapura district, you can see the worst affected areas are Medavachiya, Padaviya and Kabitigollava. And coming to the Polonnaruwa district, I will concentrate on Madirigiriya. So just to put you in the picture of the healthcare resources that are available in the region, we have the main teaching hospital where it has 2 nephrologists, 3 physicians. It has nephrology wards, clinics and the dialysis unit and a transplant unit. And there are 2 other major hospitals. One is Padaviya Base Hospital, manned by 1 physician, a renal clinic and a dialysis unit. Kabitigollava Hospital, 1 physician, hardly any facilities, even a renal clinic. There's no space to run a proper medical or a renal clinic in this hospital. And the Medavachi Hospital has a renal clinic and a dialysis unit. And you can see the distance to travel from Padaviya to Anuradhapura, though it is, the Google says is 2 hours, and actually the public transport would take quite a long time than this. Now coming to Polonnaruwa district, again, teaching hospital Polonnaruwa has the nephrology unit, the clinics, and as you are aware, 500-bed hospital is coming up in Polonnaruwa for the renal patients. Madirigiriya 1 physician, Hingurakuda 1 physician. Although the distance from Madirigiriya to Polonnaruwa is much less, the patients will have to spend almost their full day traveling, getting appointments and waiting in the queues. So their whole day is spent on one visit to a major teaching hospital. And the physicians who work at the district hospitals are either soon after board certification or they are acting physicians who are awaiting foreign training, and they do a tremendous job of work there. So the challenges in CKDu management also similar to any CKD management guideline that is available. And you have to maintain a sustainable and adequate screening program. You have to establish an accurate diagnosis. Just CKDu do not do screening programs, but CKDu, you need screening programs. You have to establish accurate diagnosis. Treatment should be delivered without undue burden to the patient. You know the traveling, how difficult. To have a fair policy in allocation of dialysis is very challenging. To provide psychological, social and financial support for these patients. So therefore, right across from the renal clinic, which is really overcrowded, the hospital beds, which are, there may be no dedicated beds in the general medical units and the other two hospitals, and to the home situations where they are coming from very poor socioeconomic conditions. So all these places are challenges to the physician has to meet the challenges at each and every point in managing these patients. And also, most of these patients are under the care of the physicians and managed in the medical clinics and the renal clinics. So this is the new case definition of CKDu. Now, the new definition has given us 3 steps in the diagnosis at different levels of healthcare. Suspected CKDu at the field level, or maybe the district general hospital level, probable CKDu, where you repeat the same criteria, the albuminuria and the reduced EGFR after about 12 weeks, and you have to exclude the other causes. And to confirm the CKDu, these patients need to be referred to a tertiary care center, and you have to get the histopathology consistent with CKDu, or if the biopsy is not permissible or not available, then you go as the probable CKDu. This is a 45-year-old man we met in Padaviya. He said, I was identified as a CKD patient at a mobile clinic. They said my urine samples were not good. So they asked me to go to the hospital for further test. I'm really worried what will happen to my family. So you can see he goes to the hospital with lot of fears and anxieties. So at the hospital, is urine albumin creatinine is available? Yes, Padaviya hospital it is available. Creatinine is available, but it is not the standardized method. So you can have some faults in calculating the EGFR. Ultrasound, it may or may not be available. Sometimes the machine may be available. So the physician, if he is interested, might travel to Anuradhapura and learn about this and come here to do the ultrasound. Renal biopsy not available. So the physician at the base hospital is left with, he has to take the decision, should I manage this patient with a probable CKDu or should I refer him to the tertiary care center for the confirmed diagnosis. So no guidelines are given with this which patient should be referred. So it is the physician should, with his experience, should decide not only the patient's illness, considering his other social circumstances as well. So during this process of diagnosis, even pitfalls in diagnosis could happen. A patient for the first time coming with serum creatinine of 6, may be albumin positive, may be red cells positive. You may overlook the presence of red cells and you might think this is CKD and might ask for a date for ultrasound. So pitfalls could happen in these situations. So the clinic follow-up. There are several things the physician should concentrate. You need good surveillance, and because you have to arrange timely preparation for renal replacement therapy. You have to avoid unplanned emergency dialysis because it increases the mortality. And you have to prepare the patient for non-dialysis palliative care. As we heard in the previous lecture, most of these patients would be having conservative management. At the end, they will need palliative care. Comorbidities, not so common as in diabetic kidney disease, but they should be taken care of. Health advice and nutrition I'll describe as I go on. So the surveillance need to detect deterioration of kidney function and follow up such patients carefully. When the GFR deterioration is more than 5 ml per minute over 12 months, or the CKD stage 4, when you think the further deterioration is necessary, abrupt changes of the renal function. So all these things, the medical officer would detect these patients and refer to the physician. So he should be following these patients and giving the clinical decisions. So again, it is a question, who should be referred to the renal replacement therapy? So you can't refer everybody with stage 4 disease. Despite, I have seen how the dialysis facilities are improved in the area. However, the number that can be accommodated for HD and KT is still limited. However, there are no criteria to refer which patient to refer, and the physician should decide. In addition, there are a lot of patient perceptions. They just think it's a disease that's due to our fate or karma, so they think they should carry on. I'll just read one or two. The patient think if you start a dialysis, it means you can't live more than 3 months. One of my relatives undergone dialysis and he died after 1 week of starting dialysis. So the patient, the consultant should counsel the patient, and they have to spend extra time to get over these perceptions. In addition, a lot of patients have resorted to various other types of religious, ritual, and supernatural healing practices, and spending quite a lot of sum of money on these supernatural and other practices. Kidney transplantation, again the patient perceptions are poor. Maybe they have seen what is happening at the very early stages when the nephrology facilities are not so much in the region. And as one CKD patient pointed out, even if I have money, I would never go for a kidney transplant. I would distribute the money among children. So they may have a better future. I must say these will change in the future because there are more people are going for the nephrology treatment and so on. So also the physicians do not have any availability or access to the data on mortality and morbidity. So they are sometimes in a dilemma with these patients. What is the mortality in these patients? If we should counsel them for this. And the physicians who are working in these areas, the counseling skills, the physicians, sometimes they feel they do not have adequate counseling skills to do this. And the follow-up, these patients have a very high symptom burden, severe anorexia, backaches, somatic symptoms, high ESR, whether they should be further investigated for myeloma, and the managing them with non-steroidals, it is contraindicated. So physicians faces problems there. Sometimes non-availability of investigations, some drugs are not available, no effective therapy, and the trial have shown that ACI is limited the effectiveness only to lower the proteinuria. And also you have to, sometimes the patient opt out for traditional medicine and after some time they come back to the clinic. So all these are challenges that the clinician is facing. And so many social issues there. And the family is greatly affected, low income, cost of health care, neglecting other family members, marital disharmony, stigmatization. So they come to the clinic with all this burden on their heads. But does the clinician have enough time? Physician has enough time to look into all these problems. Other emotional factors, associated depression, financial issues, so many other things. So as a result, I think the physician does not have enough time to look into these, and you only focus on the disease, which I suppose in the future it should change. And as a result, the NGOs also cover, there are so many NGOs which cover some social aspects. And coming to give the health advice, and the physicians are not aware the researchers are not aware what is underlying cause. So how can they tell the patient what is underlying cause? And sometimes the safety of food items, the drinking water, is it safe? Sometimes it is in doubt of the physician. So they have to be aware of the current research developments, and also sometimes they have to act against this adverse media publicity. You are all aware about the arsenic issue. What was the media publicity? The physicians working in those areas told me, we know that it is not arsenic. We have not seen arsenicose among these people, but these are the issues we have to talk to the patients, and the glyphosate issue more currently. So the nutrition and anemia, most patients are underweight. And the most of them are on very strict diet. They think they should eat few vegetables and not eat meat and fish, because they have very difficult for the physicians to change these attitudes. They also have food taboos in these areas. In addition to that, even if they agree to it, they can't get a good balanced diet due to their financial constraint. When we were visiting the houses, we have seen their food plate. It is, hardly adequate. And the management of anemia is challenging, because some areas they have like thalassemia, like in Kabitigollav, and the treatment wise, even the blood pictures are not available in these small hospitals. And erythropoietin therapy also may not be available to each and every patient. Coming to hemodialysis, the physician will have to either establish or improve existing facilities in the small district hospitals and base hospitals. And Padavi, I know the physician who took this task of establishing the hemodialysis unit. And the physician will have to manage the complications of dialysis. He needs to follow up the HD patients, because it's difficult for them to go to the main teaching hospital. So it's additional work to run a separate clinic. And also the urgent dialysis, they tell me, very challenging. The nurses does not want to do urgent dialysis because the mortality rates are very high. But they always appreciate the nephrologists. They are very supportive, accept very ill patients at any time of the day. There's no responsibility of follow-up of the transplant patients, but the patients will get admitted with complications such as sepsis, and they would always need transfer to a teaching hospital. However, to manage the sepsis guidelines, not to give the antibiotics within first hour, they are not having appropriate antibiotics, and sometimes unless the physician is interested, get down the culture bottles and keep doing a culture and giving antibiotics is almost impossible in some of the district and the base hospitals. The conservative management is an accepted form of end-stage renal disease, and all the principles I have told you would apply here. This may be large number of patients are on conservative management due to medical reasons, patient's choice, financial constraints, and majority of these patients are managed by the physicians. And there's no comprehensive management plan on advanced care planning, plans of end-of-life care, psychological care, and the spiritual aspects. So the high proportion of CKDu patients at the end will need end-of-life care, and most physicians feel the patients are not prepared for end-of-life issues. And this is one physician told me. I was working as acting physician in Padavi before my foreign training. If I had the current knowledge on end-of-life care, which I gained during my foreign training, I would have done a lot for the CKDu patients in their terminal stages. So that is one aspect. Currently the PGIM is concentrating on to improve the trainees' skills on the palliative care. Research, the physicians are in the epicenter of CKDu epidemic. However, and also we have a dearth in the data on disease progression and the patient management. However, lack of time, even though they are enthusiastic in doing that, lack of time and the lack of resources prevent them engaging in the research. So ladies and gentlemen, so this is few things that resonates in my mind about how we can overcome the challenges. We have to appreciate the huge workload on individual physicians. As you are aware, we do not have, like in the Western countries, a primary care doctors in the community. So these hospitals serve as the primary care point. So we need more expertise in these centers, although our the PG trainees who work as acting physicians do a huge workload. But whether we should have board certified physicians who will have a longer stay, and you need to improve the facilities and district and base hospitals to serve these people who are a vulnerable population. And to have satellite dialysis unit, in my impression, rather than having a huge center in Polonnaruwa, perhaps to have satellite dialysis units would be immensely helpful to these patients to save the time of traveling. And more shared care making with the nephrologist and the recognition of these physician service would be very, very important. And perhaps the future, I have just read in the most recent journal of the Royal College of Physicians, they have described very well the virtual clinic. Very practical approach, I thought, because these patients have very long-standing, slowly progressive disease, perhaps to communicate between Padavi Teaching Hospital, which is the primary care site, and to the teaching hospital Anuradhapura, and to get the nephrologist-led decisions. I think this should be perhaps one aspect in the future to overcome the challenges. Thank you very much.